Great. Thanks very much, Matt, and thanks to all of our panelists for some stimulating and provocative presentations. Let's now open it up for discussion, questions, comments, points of view. Yes.
I have first a comment. I want to make sure you distinguish between demand and need. I've heard using the word demand. What in healthcare we should target is need. We know there are a lot of children that are eligible for Medicaid but are not enrolled. So that's the difference between the demand and need. We don't target all of the children on Medicaid. We know they're undiagnosed asthma children or adults. We don't target the demand. We should target the need. We can always craft to operation research a very nicely optimal scheduling framework with the right demand. So we have to be careful what we target, demand or need. And that's really reflects the patient side. And the question I have to the panel, will a patient prefer to stay in a waiting room for an hour or stay for 2 hours in the traffic or drive for 50 miles? Which one is weighted higher for a patient?
Yes. Or more accurately, it depends. I mean, there isn't a one right answer to that. It depends on the circumstances and the person.
And it seems that we optimize scheduling the 1 hour rather than the distance or rather than the congestion.
What are you going to give me to do in the hour I'm sitting in the waiting room?
Well, what would you do with 2 hours sitting in traffic?
Depends on what kind of equipment's in my car.
Well, you can use those maybe probably in the waiting room too.
I mean, I'm not trying to be flip about it. I think it in fact makes a big difference. I've seen waiting rooms that have educational stuff on the TVs as opposed to Fox News. I live in the South where that's the only thing on the TV. You think I'm kidding, huh? You know, you can have really interesting things there. You can have resources that tell about the diseases in the area that you're dealing with. You can have computers for people to work on. An hour there for most people would probably be very interesting and valuable. You know, what do I have in my car? You know, who knows?
So what we need to be careful is what we optimize. That's what.
So how do we take wasteful waiting and add some value-added time to it? But I know our other panelists here are just chomping to jump in on this. Sarah?
I think one thing we have to understand is the difference maybe perhaps that exists between those circumstances, and that a patient in a waiting room may be very anxious about having a test because they're anxious about the results, or they may be in fact sick. And trying to deal with managing their illness at the same time that they're waiting. So I think we have to really think about the context and all of the elements that are happening in that context.
If I can add to it, I mean, it's interesting because the discussion around wait time is about time. Well, what is time? And how do you perceive it depending on the context? And your time may not be my time. And my time today is different from my time tomorrow. So I think what that says to me is that we need to figure out a more sophisticated way of looking at those measures and what time means for different people at different points in time. And that was really my point earlier on of thinking about you're going to take one solution and plug it and get the same thing. No, we're not talking about substituting. The way a systems engineer think about things is in interactions, and so that's really what we need to think about.
Yeah, yes, right here.
Ashley Benedict. I was previously the senior engineer at the New England Veterans Engineering Resource Center, and I've now moved down to VISN 8, which is the largest VISN within the VA as far as we see about 10% of the patients. So that point exactly, like this idea of perceived weight versus actual weight, and it's not the same for every patient. So some patients are willing or comfortable with waiting. I mean, you know, they might be going on a vacation. They might be going up to New England for the summer. You know, we have these different things. So is there just one measure for wait time, or do we look at kind of balancing measures for how people perceive wait times? And from that previous, like the IT component, you know, if we could predict what patients needed and their appointments coming up, and I could get my lab work done, you know, that might not be waiting time for me because there's an actual value-added activity that's happening between now and being seen in my actual appointment. So are there, you know, the balancing measure piece, like what are some balancing measures that we could start looking at when thinking about wait times?
I think you need, some people need to turn off their microphone.
Don't take it personally.
It's mine now, Gary. We share. I mean, I think this is a really important question, and I think that there are a lot of really smart people in the room that may be able to provide an answer. But let me challenge you. Why do you want to use time as a measure? I mean, why? I mean, I think I heard a lot, and again, I'm not advocating you should not do it, but I'm hearing a lot about how do you capture it? Is it good data? I mean, at one point in time, there is a trade-off between investing into that type of measure and maybe investing in some other types of measure. I think that what all of us would be saying is that you need to think about the people in the system, whether they're patients, caregivers, the physician, the nurse, the scheduler, and maybe get some data from them, from their viewpoint, and really do system design that looks at all of these different outcomes and then think about some type of trade-off analysis, because I think that's the challenge that we're facing, is designing a system for multiple users. So can we start thinking about measures that maybe more people-based measures? And again, human factors and other disciplines have invested a lot in understanding those measures, workload, perception of workload. You know, we got tons of those. If you want them, we'd be happy to share them with you. So it's really starting to think about those measures in a more sophisticated way, more complex way, because it's a complex system.
So if I could just add to what Pascal said. You know, David earlier gave an example where he had an hour wait time, and that was very frustrating, and then he had a 2-hour wait time. But the difference was that he had some agency in the longer wait time. You can stay, or you could leave, or we'll call you, or you can schedule another appointment. He was given some agency, and yet he put up with a 100% longer wait time. And so, as Pascal says, the simple measure, you know, maybe pushed by Congress, just to measure how many days, how many hours, I think it would be very interesting to see if you can test some ways that you interact with patients and then measure their satisfaction and their attitudes towards the wait time. You may find that by talking a little to patients, if you can spare the time, you may be able to, they may be able to withstand longer wait times and be as satisfied, maybe even more satisfied.
Sarah.
Yeah, just to echo what my colleague said, I think the measure has to be a multidimensional construct. I think time is only one dimension of it. And we really have to factor in things like patient satisfaction, provider satisfaction. And another important thing, I think, is expectancies and expectations. And that really has a lot to do with how satisfied or dissatisfied or frustrated someone is. So in the 2-hour example, I think the expectancy changed because information was given about what to expect and how you could manage it and why it happened.
Back there.
Just quickly, throw away your stopwatches and ask the patient.
Thank you, Chris Lehman. I think there's also a safety component. You know, satisfaction is one thing, but if you have immunocompromised patients, like oncology patients, waiting for their chemotherapy, there is a real issue there that it has nothing to do with patient safety. So there are technical approaches that we can take. We reordered the chemotherapy production process based on the time the patient arrived actually at the clinic. And as a result of that, people who were coming late Other people jumped the line to that, were able to be taken care of. On the overall wait time we were able to reduce was about 45 minutes per patient. So doing similar things for scheduling, driving the actual time you get seen based on the time you arrive or are able to attend be in the exam room, I think makes a lot of sense, and that's something we should look into.
Patty Gabo, Denver Health formerly. I hate to say this with Gary here, but I think as we try to tie the system engineering back to the context of the patient, it's really good to remember that Toyota was built on two pillars: respect for people and continuous improvement. And if we remember those foundational pillars and not the tools and not just the measurement, then I think we will be guided in the correct dimension. And often I believe those two pillars are not embedded into the culture in which we start system engineering, and so we end up at the wrong place.
And the systems engineering approach is totally misinterpreted because it's in some ways out of context. It doesn't have the receptive context. Yes, back here.
Michael Harrison, AHRQ. I'd like to pick up on a comment that David made and connect it to Pascal's presentation, and then ask David to perhaps help us out here. And that is, I think for a lot of us, when we hear the patient perspective, as patients we identify with it, but then as researchers we think, well, that's kind of the soft side, or as managers you think, well, that's kind of the soft side. We can't really do much about that anyway. I think in David's comment there's an observation that's very important, and that is if you get user-centered design, one of the things that you can do is to begin to anticipate what otherwise may turn out to be unintended consequences of some of the stuff you put in place. And Pascal is nodding because I'm picking up on her field. Obviously there are lots of unintended consequences that are emergent that you have to monitor once you've got something in place. But there's some of them that if you do your pre-planning and your scenarios appropriately, you may be able to anticipate. And David, I'd just like to ask if you can give us an example of where the patient representative or the patient advocate actually helped the schedulers avoid, falling into a trap that they would have fallen into if they hadn't taken into account the patient perspective.
One of the things that I didn't get to in the interest of time was my average wait time now is 0. And almost all of that improvement is because patients agitated to have people address the wait time issues. And the patients didn't necessarily make specific suggestions that changed it, but often they did. For example, does the person who checks you in have any idea how much backup there is? Very often they don't. All they know is you're checking in, and have a seat and somebody will be with you. So we created in some areas a system where the person at the front desk knew you're fourth in line for doctor whatever, or whatever it is, but there's a communication option that's available to the person that tells them what's going on. There are lots of other things, but as I said, a lot of what we did at our institution is very local. It's what specifically worked in a specific area that the people, including the patients, thought up in that area to try and address their problem. I know that doesn't entirely address your question, but.
Christy Dempsey, Press Ganey. This is kind of near and dear to my heart. So what we know is that the longer people wait, the more dissatisfied they are. I mean, that the correlation is there. I think, to your point, it's both. It's communication and it's reducing wait times. Because if I am constantly waiting for 2 hours at my physician office, I'm probably going to look for another physician. It's great if they tell me everything I want to know and they communicate, but I don't want to wait 2 hours. So I do think it's both, and I think we have to be very careful not to go down the inform about delays road without also going down the let's get rid of the wait road.
Great point. Thank you. In the back, and then Jim.
Yeah, just a couple of points, and I think this has been a terrific conversation. Kristen Carmen from the American Institutes for Research. It's clear that optimization and efficiency are dynamic concepts. And I think a lot of the conversation has been terrific here on the importance of transparency, because for a lot of patients and families, they don't necessarily understand how the system works. And what David is really talking about of participation is not just consulting with patients and families, but bringing them in on the front end as you design and think about what the potential solutions are. That not only has an impact on you potentially designing a system that's going to be more effective, but you also build a lot more receptive capacity for patients and families understanding how the systems work, because fundamentally they don't understand how insurance works, they don't understand how payment works. So there's lots of positive attributes of it, both in terms of what you're going to end up with the system, but also in terms of their capacities. But I want to link to another point. A lot of the conversation here we're talking about today is transferring, as systems get more efficient, we're transferring more to patients and families to do. And when we talk about bringing patients and families' voices in, we also need to bring them into this broader conversation of, guess what? If we move bundled payments and we start moving and changing a bunch of things post-acute care onto you, are you ready for it? What do you need in order to be ready for it? And how do you feel about that transfer in the system? Because efficiency and optimization is always from a perspective. Purchaser's perspective, payer's perspective, patient's perspectives, and provider's perspectives. And I think we need to do a much better job of making those differences in perspective or those commonalities in perspectives transparent.
Sarah, you have a comment?
Yeah, I'd just like to echo that. We deal with a lot of, we have a memory disorders component in our Center on Aging, and we deal with a lot of, obviously, patients who have cognitive impairment, but equally important is a family member who comes with a patient with cognitive impairment, and most of the time is totally unprepared to serve in the caregiving role, not only in terms of they don't understand the disease, they don't understand what to expect if we're talking about Alzheimer's disease in particular, but also how to coordinate the care for the patient and where to get help and support and who's paying for what, et cetera.
Go ahead.
I think your point is really important because very often we don't think about what patients and caregivers and families, I'm just going to use the term patient for now, but think about the patient work system. They actually do activities, they use technologies, they do that in their home environment or in the waiting room or they're in their car. They're organized, they have schedules, they work with other people. And I think thinking about how do we design the subsystem for them too. And one of the things that we're hearing in our study on patient health IT is sometimes some of these technologies are not designed in a way that make them usable and useful. So we need to think about them also as part of that system that we need to design.
Jim Benion.
So Jim Benion, Healthcare Systems Engineering Institute. An opinion, comment, and a question. I guess my opinion is I would agree it's better if the wait doesn't wait at all. It doesn't happen at all. And when it does, we manage that. But at some point, that wait becomes waste. We run out of emails to respond to and errands to run and things like that. This was an excellent panel. Thank you so much, and thank you, David, in particular, for sharing your time with us. And so this gets to my comment, which is going back to the beginning of the panel, you know, this committee's been meeting and talking about the problem from a systems perspective and a systems thinking perspective, sometimes a systems engineering perspective, and of course we're sort of dripping with mu and lambda and queuing and MIPS, mixed integer programming. But we haven't talked enough about user-centered design. And I think this could be a breakthrough or at least a different frame. I think it would be a contribution as a thinking exercise and as an engineering exercise to really methodically go through this, not just talk about the user and the patient's a piece of this, and of course they're at the center, but actually do a user-centered design exercise. And so I wanted to underscore that because it was at the beginning of the panel, and we've drifted into these other very important topics, but I wanted to remind everybody that that comment was made And I strongly underscore that recommendation. My question is about involving the user in the improvement work, not the design work. And we're familiar with like PCOR and involving the patient in patient safety improvement work. I haven't seen much in terms of involving the patient in improving access to the system and weights once they're in the system. And I'm wondering if other health systems here have experience with that.
Yeah, just, I know others have comments, but at Virginia Mason, we are now including patients on almost every, even remotely clinically related rapid process improvement workshop. And so they had this huge perspective where we thought we knew what they would say, and sometimes we are very surprised at their perspectives.
But I'm just guessing that's the exception and not the norm,
Yeah,
right?
but it's highly, we're finding it very valuable. We'd have time for one more comment. Patricia?
Patricia from the National Patient Safety Foundation. I think there's one other angle to think about in terms of waiting for appointments to be scheduled. And it may relate to the questions we brought up before. One is, when do you want to be seen? Do you need to be seen today? But I think another really important question for patients who have chronic disease or who require long-term monitoring is, do you have any other appointments scheduled already? And if so, when are they? And can we try to work around that so that you can combine your visits, particularly if you do have travel and distance and don't have all the resources to be able to take time off from work? And we have 2 care providers that do an outstanding job of that, just coordinating care. And the satisfaction that comes from having that question be asked and being able to try to bundle visits together has made a huge difference.
A couple comments. Dave, Sarah?
Just a quick example of that. One of the areas that I worked with directly, the check-in person once saw me leave that area, and we had worked with her to talk about processes and information flow and all of that. She saw me leave and forget to make a follow-up appointment. She called me up and said, I noticed you have an appointment with this other doctor on day such and such. Is it okay if you come in? I can't remember, it was right before or right after. So she took care of it all because she noticed and because we'd had those conversations.
Lisa, did you have a comment?
Thanks, Gary. Lisa Brandenburg from Seattle Children's. I just wanted to make a comment very specific, I think, to what David's talking about and you, Gary, which is at Seattle Children's, we've been very focused on improving our access to be 7 days or less for specialty appointments for new patients. And for 3 years, we've really driven down our number from 19 to 11 and to 8, and we're like trying to get to 7. And we started talking to the patients and tracking the data of when the patients and families want to be seen. And in fact, we found out that a lot of patients want to be seen within 7 days. A lot of patients want to be seen that day. 25% of the patients didn't want to be seen for 14 days or more. And it was just crazy that we had been doing all this work without really that direct voice of the patient and family, and really realizing we needed to be doing both. That the point is to see the patient and family when they want to be seen, right?
Great, thank you. So, great conversation. This was critical to this overall discussion, and will greatly inform the work of the committee. I think in many ways, this is about the patient and the sense of loss of control that patients have, and how can we restore that sense of control. I mean, what Don has told us over years, nothing about me without me. How can we better engage the patient, user-centered design. We also had some discussion about what I would call damage control or service recovery, or how do we take the waste and try to make it value added. The counterpoint being, can we design a system with no waste? Can we design a system that's in flow with no waiting? At Virginia Mason, this drove me crazy, but in every ambulatory clinic today, when you walk in the door of the clinic, there will be a sign, and it'll say, Dr. Smith is on time, Dr. Jones is on time, Dr. Kaplan is 15 minutes late. you know, but it's transparency, and it does help. And yet, our objective is to eliminate the defects, and waiting is really a defect. And then finally, I'd refer folks to the breakthrough work of Victor Montori at the Mayo Clinic, which he calls minimally disruptive medicine. Minimally disruptive, not in our terms, but in terms of the burden of work we put on our patients, the burden of being a patient. And I used to, you know, I am very pro evidence-based medicine, but it's evidence-based medicine that's consistent with the patient's values and applicable in their context of life and living. So thanks very much. Thanks to a great panel. We have just a brief break to get our food, which is, I believe, out in the foyer, and then bring that back in, and we have a working lunchtime presentation. Thank you.